Hi, I'm James Waslaski. I'm doing treatments here at the CryoDerm booth, and I've got a young lady here with an ankle problem that had a fixated subtalar joint and a lot of subacute inflammation. And without the wrap, without doing the wrap to the ankle, there's no way I can move that subtalar joint. So by doing the wrap and pushing the pain reliever deep into the joint, I'm now going to show you the difference of what we can do with that ankle. So when we started, there was no dorsiflexion, and just from the wrap, I want you to dorsiflexion foot. We've got about 20 to 30 degrees of dorsiflexion. You can see that she's had multiple fracture stuff here, tibial fracture here, and what we need to do is we need to calm down the pain receptors so that we can actually do the therapeutic treatment. And with the pain receptors calmed down, we'll just go into a little counter strain technique. And from the counter strain technique, we'll do a little arthrokinetics, which is really designed for joint mobilization, followed by some movement of that ankle. Now we're getting a little bit of movement there. And we'll go back into the arthrokinetics, which Judith Aston has refined techniques that create joint mobilization. So then we'll get into there. And now I want you to just start to plantar flex and then come in further into dorsiflexion. And by getting joints moving, and now I'm going to show you a great correction for a fixated subtalar joint. Just wanted to let you know in the massage world we call this spontaneous alignment of the joint, but I'll show you how we facilitate joint mobility. So we're going to bring the leg up here for just a second. So when she fractured this week, we created a hypermobile joint. The talus bone, which is space between the tibia and the calcaneus, is entrapped, and it's slid lateral and anterior. So one of the techniques I've learned from osteopaths is, number one, just take the ankle through all ranges of motion: eversion, inversion, plantar flexion, dorsiflexion. Do you feel that moving a little bit better in there? And so the big smile on her face is indicative of the fact that due to calming down the pain receptors, now I can go and do deeper therapeutic work, and now you can start to see some joint mobility coming back. You can feel it moving now in that joint, right? So dorsiflex and plantar flex. Now, to really get that to move, we've got to slide that talus back here and posterior. So I just come in here, I traction, I dorsiflex, and I do a motion that can actually take the talus back into a medial position and a posterior position, and now start to dorsiflex your foot. And now it's a big smile on her face. That's good. It changes the muscle firing patterns of her face by changing the joint fixation problem. And you see how that made a difference by doing the